Hello, I'm Tiago Rosito from Hospital de Clínicas de Porto Alegre and head of pediatric urology in Brazilian Society of Urology, talking here to SBU TV with one of the goats of pediatric urology world, Professor Tony Khoury from University of California, Irvine. Uh, Tony Khoury is the 10th time here in Brazil this year, and thank you, Prof, to be once again in Brazil with us.
It's always a pleasure. I mean, my first visit was back in 1997, and I always felt very welcome in Brazil. I love the Brazilian hospitality and great food and the great friendships we've had over the years.
Prof, the Brazilian society gives a lot of opportunity to pediatric urology. One of the main stem of the Brazilian society is make pediatric urology bigger and stronger in Brazil. What your impression with this 10-time difference
Oh,
about pediatric urology in Brazil?
huge. I mean, I remember the first time I came, the meeting room was quite small. There's maybe a third of the number of pediatric urologists in Brazil. Um, you know, 25 years later, our meeting room is full. There's I think it's almost as big as some of our meetings, pediatric meetings at the American Urological, with the number of attendees. And it's great to see the interest in pediatric urology by the young people in the Brazilian society. Uh, and I look in the United States, the interest in pediatric urology in the younger generation is decreasing, and the number of applicants for fellowship positions is decreasing. Whereas here, I see a blooming growth in interest and in the number of pediatric urologists that attend the meetings.
Well, great. We are very happy to hear about this. And Prof, you came here to talk a lot of things. One of them it's about myelomeningocele bladder, neurogenic bladder. And what do you think is the future of the neurogenic bladder and myelomeningocele nowadays in the future?
Well, it starts with the prenatal diagnosis. The prenatal intervention, I think, eventually is going to make a difference. We're already seeing some milder bladder damage, and a lot of these children being born with normal bladders and normal kidneys with the prenatal intervention. I think the earlier diagnosis is leading to planned deliveries and better perinatal care for these children. Um, Remember that 95% of these children have normal kidneys at birth, and our job as clinicians is to protect those kidneys for the rest of their lives. Renal failure in the myelomeningocele patient should be a thing of the past. If the children are followed prospectively and they follow their medical and catheterization regimes, it should cut down a lot on the need for surgery, especially with the minimally invasive approaches. We heard some talks about botulinum toxin injections in the bladder today and how that could delay the need for augmentation or abolish it almost completely.
Uh, are you in favor or against a proactive management of the neurogenic bladder since the newborn period?
No, we have a very proactive approach. It's almost, you could say, too aggressive. So we start everyone on, we assume everybody's going to need to be catheterized. We start them on catheterization, we start them on oxybutynin, and then as they progress, we tailor their treatment. But we start very aggressive at the beginning because we want to prevent any early deterioration. And then as the child grows and we understand what the pathology is going to be, we might taper their interventions. And then we keep a very close watch as they go through their growth spurt because retethering of the spinal cord is a real thing in this population. And we have to be very careful not to allow it to uh, cause damage, to be reassured by the early success and then end up with at puberty damaged bladders and subsequently damaged kidneys.
We are here talking to adult urologists as well. What do you think is the better way to do a transitional clinic to pass our patient for the adult urology patients?
Yeah, that is a challenge. It depends on the area. For example, at the University of California, I do my own transition. So I have an appointment at the adult hospital at the UCI Medical Center, and I do my own transition there. So I see the patients still in the pediatric clinic until they're 30, 35 years of age. And if they need surgery, then I take them to the adult hospital, to the medical center where we do their surgery. And I'm mentoring some of our younger reconstruction colleagues there to eventually have them take over the care of these patients.
I'm very, very happy to hear about this because it's exactly what I do in Porto Alegre because I take care of the kids, the teenagers, and even the adults with congenital problems. We manage all them, and I really think that's the better way.
The patients feel very comfortable with you. The families have known you since the child was a baby, and there's something to be said for continuity of care. Unfortunately, when they transition to an adult hospital, they frequently get lost in the big, adult clinics, and in our pediatric clinics, they always get very personalized care that sometimes is lacking on the adult side.
Thank you, Prof. I would like to thank you once more to come to Brazil once more and prepare yourself because you will come back.
Thank you.
Nice to see you again,
Appreciate it.
Prof.
Yeah.
Thank you.